So everyone, welcome to CED Ability Grand Rounds. Appreciate everyone joining us for the month of April. Just as a reminder, before we open it up to Dr. Wang, please make sure that your lines are muted until you have a question. Please utilize the chat throughout, and then at the end we'll have questions and answers. So feel free to be very active in the chat as much as possible. When you can, leave your video on, but we understand that during you need to turn it on. So feel free. Either way, we're just happy that you joined us. So Dr. Wang, let me tell you a little bit more about her. So as you see on her slide, she's assistant professor in the Department of Social and Behavioral Sciences at Yale School of Public Health. A little bit about her research. Her research broadly focuses on the role of stigmas as a psychosocial determinant of mental and behavioral health disparities. So she's going to talk a little bit about ableism and some of her latest work. And with that, let me turn it over to Dr. Wang. Dr. Wang, thank you very much for joining us.
Of course, thank you for having me. So I want to just quickly thank Leslie for inviting me and for your very kind introduction. And it's a true pleasure for me to be here today to share some of my work with you on the interpersonal and health consequences of ableism. So I am a social psychologist by training, so I've been studying stigma for a long time. I also personally identify as a member of the disability community as I've been blind for most of my life. So a lot of the work I am presenting today has been informed by my own lived experience, and I'm very excited to have the opportunity to share this research with a broader audience. Before I dive into my presentation, I just want to give you a quick overview of my talk today. So I'm going to start by giving you a little background information on the definition and scope of ableism. So by ableism, I am referring to stereotyping, prejudice, and discrimination that is directed towards people with disabilities. I will then highlight patronizing help as a subtle but insidious form of ableism. And to do this, I'm going to present a series of 4 studies I have conducted over the past couple of years. These studies look at how patronizing help is perceived and what happens when people with disabilities confront patronizing help. For the last part of my talk, I'm going to pivot a little bit, and I'm going to talk about an ongoing project in my lab, which examines the lived experiences of people with disabilities during the COVID-19 pandemic. Unfortunately, disasters and public health crises have a tendency to magnify the consequences of stigma and exacerbate any health inequities that already exist. We have seen this happen with communities of color since the start of the pandemic, and people with disabilities are unfortunately no exception. So I think it's really important and timely for us to shed some light on the overall mental health impact of the pandemic on people with disabilities, and also to identify some of the unique sources of risk and resilience facing this community, especially in relation to experiences of ableism. So to begin with some basic definitions, disability is defined as a physical or mental impairment that substantially limits major life activities. While many of us might be under the impression that people with disabilities only represent a small minority of the general population, this is actually not the case at all. According to recent data from CDC, disability affects 1 in 5 adults in the United States. So that's 20% of our population. And even those who are not disabled at this moment in time might actually acquire disability at any time through a number of circumstances, such as illness, injury, or just the reality of aging. In fact, with the high number of COVID cases and the fact that a lot of people are experiencing COVID complications after recovering from acute infection, we are actually going to see more and more disabled individuals in the next couple of months. An important barrier that people with disabilities often encounter across a number of life domains is ableism. Now, I think it's really important to acknowledge that our society has become significantly more accessible and more inclusive for people with disabilities since the passage of the ADA, which stands for Americans with Disabilities Act. This law was passed in 1990, and in the past 30 years or so, people with disabilities have been able to participate in different life activities at significantly higher rates compared to before. However, the reality is that ableism still remains extremely pervasive in a lot of contexts. So, for example, people with disabilities still routinely face employment discrimination when they are trying to find or keep a job. And accessibility issues are unfortunately still very common. These issues might include things like lack of ramps or elevators for wheelchair users when they're trying to navigate a building, or they might include things like websites that are not compatible with screen reading software for people who are blind. People with disabilities also encounter regular instances of discrimination in healthcare settings, such as inaccessible facilities, inaccessible forms that people who are blind cannot fill out independently, or patronizing attitudes from medical providers. So it's unfortunately quite commonplace that doctors will try to speak to disabled patients, family members, or friends who are accompanying them to their appointments instead of to the disabled patients themselves. These accessibility issues, both on the interpersonal and structural levels, can make it more difficult for people with disabilities to get the medical care they need. And this is one of the major reasons why people with disabilities are significantly more likely to experience a number of chronic physical and mental health conditions compared to their non-disabled counterparts. And it's fair to say that ableism is believed to be an important factor that explains these physical and mental health disparities. So for the first part of my talk today, I'm going to focus on how ableism can manifest itself on the interpersonal level by coloring the interactions between people with and without disabilities. A key factor that drives ableism in the interpersonal context is the ambivalent stereotype of people with disabilities as warm but incompetent. So one consequence of these stereotypes is that people with disabilities are often treated like children. As one example, when college students gave directions to an adult using a wheelchair, they tend to use vocabulary and a tone of voice that they would normally use with a 12-year-old child. And this happened even when the disabled adult was clearly identified as a working professional. Another consequence of these ambivalent stereotypes is that people with disabilities often receive unsolicited help that they don't really want or need. Although it's generally well-intentioned, unsolicited help can come across as extremely patronizing because it's based on this assumption that its recipients are not capable of handling their own affairs. People who receive unsolicited help tend to experience more negative emotions and lower self-esteem. And accepting unsolicited help can also reinforce the stereotype that people with disabilities are incompetent. These negative consequences present a dilemma for people with disabilities. On one hand, individuals might wish to assert their independence by declining any unnecessary help. But on the other hand, declining such assistance can result in significant interpersonal backlash, where members of the public come to see people with disabilities as ungrateful and rude. So to better understand this dilemma, I conducted 2 sets of studies where I investigated the issue of patronizing help for people with disabilities. The first set of studies, which I labeled as studies 1 and 2 in this presentation, were conducted as part of my dissertation, and they were published a couple of years ago. And they essentially provided an initial investigation of how patronizing help is perceived by blind versus sighted people. And it also looked at how blind people are perceived by sighted participants when they confront patronizing help. The second set of studies, which I refer to as studies 3 and 4 in this talk, were conducted more recently as a replication and extension of the first 2 studies. Specifically, we looked at some intersectionality issues in terms of how disability and gender might come together to shape the perceptions of patronizing help. And we also looked at whether the results we found with blind people would potentially generalize to people with other physical disabilities. So in the first study, I began by examining whether people with and without disabilities might have different views on patronizing help. Specifically, I tried to address the research question of whether blind people will perceive patronizing help as less appropriate compared with sighted people. So we know from previous research that majority and minority group members often view positive stereotypes very differently. As one example, whereas white participants tend to find stereotypes such as blacks are good athletes to be complimentary, black participants found these stereotypes to be prejudiced and restrictive. Based on these results, I hypothesized that whereas sighted people will find patronizing treatment to be more appropriate than hostile treatment, blind people will actually find both types of this treatment to be highly inappropriate. So we had a total of 268 participants in this study. This included 166 sighted participants who were recruited from Amazon's Mechanical Turk, also known as MTurk. And we had 102 blind participants who were recruited through email listservs that are affiliated with national blindness organizations. So for those of you who might not be familiar with MTurk, it's an online platform that allows individuals to complete surveys in exchange for small payments. And in the past couple of years, MTurk has become a very popular data collection tool for social scientists. And there is evidence suggesting that the quality of MTurk data is comparable to the quality of survey data collected using more traditional recruitment methods. Participants were randomly assigned to read one of 2 possible scenarios in the study. So in both experimental conditions, they were told that Mary, who is a blind working adult, was walking by herself using a white can. And she stopped at a street corner to ask a pedestrian for directions to the nearest bus stop because her regular route to work was blocked by construction. In one version of the scenario, the pedestrian responded to Mary in a patronizing way. So instead of just answering her question, the pedestrian grabbed Mary's arm without her permission, and they said, "Oh, it's too dangerous for you to be walking around by yourself. Let me take you to the bus stop." In another version of the scenario, the pedestrian responded to Mary in a hostile way. So they said, "Oh, it's too dangerous for you to be walking around by yourself. You should turn around and go home." We then asked participants to rate the extent to which they perceive the pedestrian's behavior as appropriate using 4 items. So these items include appropriate, helpful, condescending, and overbearing, with the latter 2 items being reversed scored. So here is a graph of our results. So there was a significant interaction between treatment type and participant disability status. So for sighted participants, patronizing treatment was perceived as more appropriate than hostile treatment. But if you look at the bars for blind participants, you will see that there was no significant difference in the perceptions of patronizing versus hostile treatment. In fact, given that perceived appropriateness was rated on a 1 to 7 scale, you will see that for blind participants, they perceived both types of treatment to be highly inappropriate. So what these results are telling us essentially is that there is a significant divergence in terms of how blind and sighted people perceive patronizing help. And this discrepancy in perspectives might have important downstream consequences when it comes to how blind people are perceived by the sighted public. So in study 2, I examined some of these consequences by looking at how the blind target person might be perceived by sighted participants when she confronts patronizing versus hostile treatment. Specifically, I hypothesized that the blind target who confronts the sighted pedestrian will be perceived as less warm than her non-confronting counterpart, especially when the pedestrian behaves in a patronizing rather than hostile manner. I also predicted that this interaction will be mediated by the perceived appropriateness of the pedestrian's behavior. So in other words, participants will penalize the target more for confronting patronizing treatment because they feel that the target is just overreacting to what should have actually been considered as appropriate or helpful behavior in the first place. We had 249 entered participants for this study, and all of them self-identified as sighted. As in study 1, we manipulated the pedestrian's behavior to indicate patronizing versus blatantly hostile treatment. In addition, we also manipulated the blind target person's response to indicate either confrontation or non-confrontation. So we had a very similar scenario from study 1. Again, Mary, who is a blind working adult, was walking by herself, and she stopped to ask pedestrian for directions. After describing the pedestrian's behavior as patronizing versus hostile, we also described the blind target's response. So in the confrontation condition, Mary responded by saying, "I can handle myself just fine and was only trying to get some simple directions." Whereas in the non-confrontation condition, she said nothing and either just accepted assistance being offered in the patronizing condition, or she just walked away in the hostile condition. After reading the scenario, participants first indicated their perceptions of the pedestrian's behavior using the same 4 items from study 1. They also provided ratings on their perceptions of how warm and likable Mary is as a person. So as you can see from the graph here, Mary was perceived as significantly less warm when she confronted the pedestrian, and this penalty was especially pronounced when Mary confronted patronizing rather than hostile treatment. I also conducted the mediation analysis with only those participants in the confrontation conditions, and I found that perceived appropriateness of the pedestrian's behavior significantly mediated the effect of treatment type on target perceptions. So in other words, participants penalized Mary more for confronting in the patronizing condition because they believe that the pedestrian's actions were more appropriate in that case than in the hostile condition. Taken together, these 2 studies illustrate that people with and without disabilities tend to view patronizing treatment very differently. And this discrepancy in perspectives can lead to a significant backlash against people with disabilities who refuse such assistance by engaging in any kind of direct confrontation. You might have noticed, however, that in both studies, the blind target person was depicted as female because we have been calling her Mary. So when I presented these findings over the past few years, many people have asked me about how these results might generalize to male targets. Others have also asked how my results might generalize to people with physical disabilities other than blindness, given that patronizing help is a common experience for people with a wide range of visible disabilities, not just for blind people. Both of these questions are really important, but I actually did not have answers to either of them because people with disabilities are typically studied as a homogeneous group, and we know very little about how intersectionality and different types of disabilities might shape the experience of ableism. So in order to provide a more nuanced understanding of the perceptions of confronting patronizing help, I decided to conduct 2 additional follow-up studies to address these questions. So in study 3, we addressed the question of whether blind men and women might be perceived differently when they confront patronizing help. Because there is so little existing research on intersectionality and disability, we began this study with 2 possible hypotheses. The first possibility is the double jeopardy hypothesis. So this is the idea that people with multiple stigmatized identities will experience increased discrimination with each additional stigma. If this perspective were to apply in the context of the current study, then blind women will be expected to encounter both disability and gender bias. And because women are often stereotyped as passive and dependent, just like people with disabilities, we might expect that blind women will be penalized more for confronting patronizing help compared to blind men. Another possibility is the primary stigmatized identity hypothesis. So this is the idea that for people with multiple socially devalued identities, one of their identities may emerge as a primary source of stigma. Consistent with this perspective, previous research has shown that both men and women with disabilities tend to be stereotyped as incompetent and dependent. So in the context of the current study, it's possible that the penalty for confronting patronizing help will be similar for both blind men and women. So for this study, we had 137 undergraduate students as participants. We manipulated target gender by randomly assigning participants to read one of 2 possible scenarios. So one version of a scenario describes someone named Mary, which is the female condition, and the other version of the scenario describes someone named Matt, which is the male condition. So this was a pretty straightforward experimental manipulation. Across both experimental conditions and consistent with studies 1 and 2, Mary or Matt was described as a blind working adult who stopped to ask pedestrians for directions. Instead of providing verbal directions as requested, the pedestrian grabbed Mary or Matt's arm without their permission and tried to steer them across the street. And Mary or Matt declined this patronizing help by engaging in assertive confrontation. Because we've already established in study 2 that confronting patronizing help tends to incur more interpersonal cost than confronting hostile treatment, we did not include either hostile treatment or a non-confrontation response as control conditions in this study in order to avoid ending up with an overly complicated study design. So participants were asked to rate Mary or Matt with respect to their perceived warmth using the same items from study 2. They do this at 2 time points, so this is a little bit different from the previous studies. There's a within subjects design to this study. So basically, participants rated the target person first before they engage in confrontation with the pedestrian, and then again after they engage in confrontation with the pedestrian. Our goal was to see whether there will be a significant decrease in perceived warmth over time, which will indicate an interpersonal penalty associated with confrontation. Additionally, we also wanted to see whether the extent of this penalty will be different for Mary versus Matt. In other words, we wanted to see whether the extent of the penalty will be moderated by target gender. So here is a graph of our results. So the y-axis here represents the difference in perceived warmth between time 1 and time 2. So again, time 1 refers to baseline before the blind target person confronted the pedestrian, and time 2 refers to after the blind target confronted the pedestrian. There was a significant decrease in perceived warmth from time 1 to time 2. So consistent with studies 1 and 2, participants rated the blind target as less warm after they confronted the pedestrian. In addition, we found support for the primary stigmatized identity hypothesis because we see that this change over time was not moderated by target gender. So in other words, both Mary and Matt were penalized to a similar extent for confronting patronizing help. And this is consistent with the idea that men and women with disabilities tend to be stereotyped in similar ways. Now that we have shown that the consequences of confronting patronizing help are similar for both blind men and women, we turn to the second question that motivated this new set of studies, and that is whether the same pattern of results might generalize to targets with another physical disability. So in study 4, we look at how people who use wheelchairs are perceived when they confront patronizing help in comparison with people who are blind. We chose to focus on people who use wheelchairs in this study because they represent an important segment of the physical disability community. And like those who are blind, they also report common experiences of receiving patronizing help because their disability is also highly visible. There has been very little research that focused on the heterogeneous experiences of people with different types of disabilities. So this study was largely exploratory, and we did not have any specific expectations or hypotheses before implementing the study. We had 368 entered participants for this study. So participants were randomly assigned to read one of 4 possible scenarios. In these scenarios, Mary or Matt was described as a working adult who is either blind or they are described as using a manual wheelchair. The scenarios we use here are similar to what we used in previous studies, but we did make one important modification. So as you might remember, in the previous studies, Mary or Matt asked for directions from a pedestrian because their regular route was blocked by construction. So in a sense, the disabled person did initiate a request for help, even though the response from the pedestrian was clearly excessive and inappropriate. One could argue that the help was not entirely unsolicited. Now, in this study, Mary or Matt was approached by a pedestrian and treated in a patronizing manner when they were simply waiting to cross the street. And we made this change because we wanted to see whether the interpersonal penalty associated with confrontation will be mitigated when the help being offered is completely unsolicited, and therefore it should be perceived as more clearly inappropriate. So as in study 3, participants rated Mary or Matt with respect to their perceived warmth, both before and after they confronted the pedestrian. And in this study, we are primarily interested in whether the change in perceived warmth over time will be moderated by target disability type. So again, we have a graph here with change in perceived warrants from time 1 to time 2 on the y-axis. And replicating study 3, we found a significant decrease in perceived warmth over time. So both Mary and Matt, regardless of their disability, were perceived as less warm after they confronted the pedestrian versus before they engaged in confrontation. We also found a marginally significant interaction between time and target disability type. So although the target who is blind and the target who uses a wheelchair were perceived similarly at time 1, the blind target was perceived as significantly less warm at time 2 relative to the target who uses a wheelchair. This suggests that the blind target was penalized more for confronting patronizing help compared to the target who uses a wheelchair. We are not really sure why this was the case, but one possibility is that members of the public might perceive blind people as more dependent and needing more help compared to people who use wheelchairs. This is consistent with prior survey research, which show that blindness tends to be ranked as one of the most feared disabilities by members of the general public. Another possibility is that when the pedestrian grab onto Mary or Matt's wheelchair, participants might recognize this behavior as unsafe, because if they are not sure how to operate the wheelchair correctly, they can potentially cause Mary or Matt to fall out of their chair and actually result in personal injuries. Whereas the treatment in the blindness condition might be seen as more harmless, because the blind person can just refuse to follow the pedestrian. There is no sort of physical interference with their movement, and there's no potential for personal injury in that case. So just to summarize, studies 3 and 4 clearly show that people with disabilities encounter significant backlash when they confront patronizing help. These effects were replicated across both NTERC and student samples, and they remain robust across target gender and disability type. In addition, these studies also highlight the importance of attending to intersectionality and diversity within the disability community when studying the experience of ableism. We saw a lot of unexpected findings in these studies, given the no effect of gender, for example, and the fact that people who are blind tends to be penalized more for confronting patronizing help than people who use wheelchairs. And we would not have been able to see those insights if we had not conducted those studies to address intersectionality more explicitly. So far in this presentation, I've been focusing on one very specific form of ableism, which is patronizing help. Of course, it goes without saying that ableism can also manifest in a number of other ways, both on the interpersonal level and on the structural levels. So for the last 10 minutes or so of my presentation, I'm going to switch gears and share with you some of my very recent data on how ableism is shaping the lived experiences of people with disabilities during the COVID-19 pandemic. So since the start of the pandemic, there has been a lot of anecdotal evidence suggesting that members of the disability community have been experiencing structural and interpersonal barriers that are driven by ableism. For example, there have been a lot of concerns about medical rationing due to stigma in healthcare settings. More specifically, when there is a shortage of hospital beds or ventilators, people with disabilities who are seriously ill from COVID might not get the treatment they need because some doctors operate on the misguided assumption that people with disabilities have a low quality of life than their non-disabled counterparts. There have also been concerns about COVID testing and vaccine access. So for example, if someone who cannot drive is experiencing COVID symptoms, it will be very difficult for them to get to a testing site because there is really no medical transport that's available for this purpose. The person will essentially either need to ask a family member or a friend for a ride, or they will need to use public transit. And of course, either of these options is problematic because they can potentially expose others to the virus. In terms of vaccine access, many states are using registration systems that are not accessible with screen readers, which prevents blind and visually impaired people from booking their vaccine appointments independently. Some states offer a phone line for people to call, but there might be long wait times, and it might just be a lot harder for people to get appointments if they cannot navigate the web portals. A large number of vaccine clinics are also drive-through only, which are obviously not accessible to those who can drive. So again, it kind of limits people's options in terms of getting vaccines, and it can result in people with disabilities falling behind in terms of getting vaccinated. Motivated by these experiences and narratives I've been hearing about, I launched a mixed message study last fall to gather some information about how the pandemic is affecting the mental health and quality of life of people with disabilities. The first phase of the study was an online survey. We finished data collection for this phase in January, and I'm going to share some of the preliminary results with you momentarily. Later this year, we are going to follow up with qualitative interviews with a small subset of survey respondents. And we want to do this because we want to get a more in-depth understanding of the disabled lived experience during the pandemic. So for the online survey, we had a total of 468 participants. These participants were adults living in the United States who self-identified as having a disability, and they were recruited from disability-focused social media platforms and email listservs. 50% of the sample were female, 70.1% of the participants were white, and around half of the participants identified as having a physical disability. Participants completed measures that pertain to their mental health and a number of related psychosocial processes. So in our initial analysis, we focused on depression and anxiety as our outcomes of interest. And we hypothesized the experience of social isolation and disability-related stigma will be positively associated with both depression and anxiety symptoms. One thing I want to point out about disability stigma is that it's actually very difficult to locate a validated measure of ableism experiences. So what I ended up doing for this study is that I adapted a measure that was originally developed to capture chronic illness stigma to assess disability stigma. And I think similar things have been done before, and this all just points to how neglected and understudied ableism has been in the existing literature. We also included several other variables in our analyses because they have been known to correlate with mental health in prior research. So specifically, we included questions about experiences related to the COVID pandemic, such as whether participants have had COVID, whether they have lost their family member or close friend to COVID, how worried they're about either contracting COVID or having a family member or a close friend contract the disease. And finally, we also assessed the number of pandemic-related stressors participants have experienced. We also included demographic questions in our model as covariates, as well as whether participants have been diagnosed with a mental health condition prior to the pandemic. We also included things that are more disability specific, such as year of disability onset, level of functional impairment, and whether participants had a pre-existing mental health condition before coming into the pandemic. We use hierarchical regression for our analysis, so we enter those variables related to COVID experiences in step 1. We enter demographic variables and disability attributes in step 2. And in step 3, we enter stigma and social isolation. In addition to these quantitative measures, participants also responded to 3 open-ended prompts regarding their experiences during the pandemic. Specifically, they were asked to describe a particularly difficult or stressful moment during the pandemic, which we refer to as the low point. They were asked to talk about a positive moment during the pandemic, which we refer to as the high point. And they were also to write about a specific moment during the pandemic when their experience as a disabled person was especially salient or clear. So here are the results from our regression analysis with respect to depression. So the coefficients presented in this table are from the final step of our model where all variables of interest are included. The rows that are highlighted in yellow represent terms in the model that are statistically significant. So consistent with our hypotheses, disability-related stigma and social isolation were both significant predictors of depression symptoms. In terms of COVID-related stressors, worries about either contracting the disease or having a family member or a close friend contract the illness was positively associated with depression, which is not surprising. And in terms of disability-related attributes, people with pre-existing mental health conditions, more recent disability onset, and greater functional impairment experienced higher levels of depression. Finally, in terms of demographics, younger participants and participants from racial or ethnic minority groups reported higher levels of depression. Here are the results with respect to anxiety symptoms. The patterns of findings are generally pretty similar to what we found with depression. So for the sake of time, I'm not going to go over this in detail. But as you can see here, basically, this initial analysis highlight the important roles that ableism and social isolation can play in terms of exacerbating the mental health impact of the pandemic for people with disabilities. In addition, these results also suggest that some segments of the disability might be more vulnerable to the psychological impact of the pandemic. These people might include disabled people of color, for example, young adults with disabilities, and also people who live with higher levels of functional impairment, such as pain or fatigue. So this suggests that future interventions might want to target certain segments of the disability community to make sure their mental health needs are met. We are still in the process of coding and analyzing participants' responses to the open-ended prompts, but I do want to share with you 2 participant quotes that I find particularly illuminating. So this first quote here speaks to the fact that ableism can manifest as the implicit assumption that disabled lives are inherently less valuable. So this type of ableist beliefs is also a main driver behind practices of medical rationing, which I talked about briefly earlier. So this participant wrote, "One person told me that everybody needs to just contract COVID so we can have herd immunity and get past everything. When I mentioned that it would probably kill me, they just shrugged their shoulders and acted like it was a small price to pay, like my life is less valuable than theirs. It was an eye-opening experience that confirmed what I already knew. Able-bodied people think that physically disabled people are seen as a burden to society and nothing more." I want to end on a more positive note by highlighting the resilience of the disability community despite the pervasiveness of ableism and housing inequities. So one thing I believe very passionately is that people with disabilities have a lot of agency and dignity in terms of how we approach ableism and how we navigate different challenges in society. So there tends to be this common perception of disabled people with victims, and I think this quote really counters that misperception. So this participant wrote, "I realized how much wisdom, skill, and resourcefulness I had gained because of my disability long before the pandemic. As a disabled person, I already had the skills, the mindset, and the knowledge to survive this. I already had masks and hand sanitizer. I already knew how to do everything by Skype or Zoom. I have been doing all of this for a lifetime. So when COVID turned the rest of the world upside down, I feel steady, skilled, and confident. So I think what this quote really highlights is that living with a disability is very much about being adaptable and being resourceful. And for some of our participants, these experiences have prepared them well for the challenge of the pandemic. So to conclude, ableism remains pervasive in today's society. It can take many forms, and its consequences can be magnified in the context of a crisis or a disaster. So in order to improve the lives of people with disabilities and to achieve health equity, we need to intervene on both individual and structural levels to create a more inclusive society in which people with disabilities can strive. So with that, I just want to acknowledge some of my mentors, collaborators, and research assistants who have supported me as I pursue this program of research. I know I've gone over a little bit, but we still have 10 minutes, I believe, so I will be happy to take any questions that people might have.
Absolutely. Thank you, Dr. Wang. That was a really, really interesting presentation and something on a topic that I think we've touched on without calling it ableism, touched on in a couple of different ways. And it's just amazing to see how you've put it all together in the story that you've told. So thank you for sharing.
Thank you.
Let's see, and I'll take a look at the chat, but while we're doing that, does anyone have any questions about the series of studies?
Dr. Wang, I'm just really excited to hear what's next. If you don't mind sharing, giving us a little bit of a sneak peek.
Yes, so we are in the process of finalizing the qualitative analysis for the disability and COVID study. The two quotes I shared really just touch the surface. There is a lot more that our participants shared, and I found their responses super insightful. So after we are done with that analysis, we are going to write up the paper for publication. And as I mentioned earlier, I will be conducting more in-depth, semi-structured qualitative interviews with some of our participants just to get a better sense of the disabled life experience. And also, you know, it's been a couple months since we collected the survey data. So there is a lot of issues in terms of vaccine access that have not been touched on in the surveys. I really look forward to unpacking those issues more in the follow-up interviews.
Kind of related to that, you know, we were just talking about there's funding going to the UCEDs for addressing COVID vaccinations for individuals with disabilities and their families. A lot of that and the literature, the fact sheets and things of that sort that we've seen for COVID, I wonder if you've had a chance to look at them and see, is there some ableism in those documents? Like, do we, you know, you spoke of strength and the quote spoke of strength and leadership. And I'm just wondering if there's a way that we need to focus on that.
Yeah, I have not had a chance to look at those documents, so I'm not sure. But I do think, you know, in general, people do tend to focus on the deficits of people with disabilities instead of their strengths and their assets. So I think, you know, overall going forward, it will be really helpful if there can be a more strengths-based approach. And I think in order for that to happen, what really needs to happen is that we need to have more disabled voices at the table. So when people are, you know, putting together these documents and guidelines and so on and so forth, you know, having people with disabilities participate in those conversations and those processes will really ensure that we are capturing the strengths of the community, but also addressing any challenges that we are facing.
We also have a question in the chat, Dr. Wang. Should we never offer to help a disabled person in situations like your scenarios? And if so, what's the better way to approach?
That's an excellent question. So what I always say in response to that is that it never hurts to ask. So there's nothing wrong with offering to help. What's problematic is that people assume that the person needs help and then they help without permission. So if you recall from the scenarios, the pedestrian essentially grabbed onto the blind person's arm without even asking whether this if this is okay. So how I would suggest is that if you see a disabled person and you think they might need some kind of assistance, feel free to approach them and say, hey, do you need some assistance here? Do you need assistance crossing the street? Do you need assistance, opening this door? And then let a disabled person take the lead. If they say yes, and ask them how you might help, right? Like, do you want them to hold on to your elbow, or what kind of assistance do they actually need? If they say no, then please respect their boundaries and just move on, because people with disabilities have been living our lives for a long time, so we kind of know what assistance we need or don't need. And I personally am always very happy when people ask me whether I need help, but what becomes problematic is when people make the assumption without asking first.
Thank you for that. And speaking of that, what are your suggestions for trainings? Training on interactions and offering these scenarios. What would that encompass based on your work in terms of an intervention?
I think contact with people with disability is definitely very important. So again, bringing disabled voices to the table, I think will really go a long way in terms of helping non-disabled people interact with us in a more equitable and respectful way. So having speakers with disabilities come in and talk about what they need, their preferences, and what interaction dynamics might be best will be very helpful. I guess another thing I would say is that, there's no reason to make this super complicated, right? Like, I think essentially we just want to be treated as like others, like just treat us the way you want to be treated. Essentially, that's what I was trying to say. So, if you don't want someone to touch you or go into your personal space without your permission, then don't do that to a disabled person. If you prefer to be spoken to directly when you are having a conversation, then please speak to the disabled person directly, not to people who happen to be around them. A lot of times it is about respect, and it is about treating others the way you want to be treated. So it can be pretty simple.
The golden rule. Absolutely. Well, thank you, Dr. Wang. We're close to 3 o'clock, and unless someone has any other parting questions, we will close out. We appreciate your time. We've learned a lot from your research, and we hope to keep up with your work moving forward.
Sounds great. Thank you so much for having me, and thank you for everyone for listening to my presentation.
Our pleasure. Have a good afternoon.
You too. Bye.
Thank you, everyone.